The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now, I'd like to introduce our speaker for this evening. Um, our presenter this evening is Dr. Martin Franklin. This is Dr. Franklin's fifth appearance on our Wednesday webinar series, and we are delighted to have him back. His previous webinars have covered broad range of pediatric neurological issues such as phobias, hoarding, trichotillomania, and pediatric OCD. If you have any interest in any of these topics, they are all available for a free download from our website. Dr. Franklin is an associate professor of psychology at the University of Pennsylvania School of Medicine and director of Penn's Child Adolescent OCD, Tics, Trichotillomania, and Anxiety Group, better known as Cottage. Dr. Franklin has presented on the psychopathology and treatment of pediatric OCD, trichotillomania, and related conditions in lectures and workshops both nationally and internationally. For over 20 years, he has conducted clinical research on OCD, trichotillomania, Tourette syndrome, and related disorders across the development spectrum. He is a member of the Science Advisory Board for the OC Foundation and the Trichotillomania Learning Center, patient organizations that are devoted to disseminating knowledge and improving patient and family access to expert clinical services for these often impairing conditions. Now, without further introduction, I'm pleased to turn over tonight's presentation over to Dr. Franklin.
Well, good evening all, and thank you for coming. I'm going to try my very best to leave plenty of time for questions. And so I'm going to start off by talking a little bit about our topic of interest, which is our teens and young adults. I'm going to start off with a visual summary of this period of life, and beginning with lovely and delightful people who seem to really like each other, smile a lot, and have lots of interesting things going on. It's a huge time of transition, and they value their friends tremendous amount, and what they value less than they used to, which is unfortunate for us, is our opinion. Now, this is Mark Twain, who I think put this nicely. I think a lot of adolescents, when you're giving them sage advice, are contemplating something like this. And we have to begin to accept that the period of life that they're going through, the most important process they're going to have to achieve is independence.
Dr. Franklin, could you speak up a little?
Yeah. So we're really trying to help them foster independence. And in order to do so, we're going to have to tolerate some of their beliefs about us and and about our own beliefs as well. I will get to this later, but one of the key issues for parents and I think for providers as well is to ignore tone, because they're going to come with lots of tone. They're skeptical about us, and they're trying to form their own opinions. And they're going through a lot of difficult stuff, some of which may not appear to be difficult to us, some of which probably would. For example, this particular picture here could be about someone glanced at me in a way that made me feel badly. This could also be about serious problems I'm having at home, and they're seeking out the support and assistance of their peers. Peers are critical. And so we also have to understand that they may be more likely to talk to their friends at this point than they would be to us. And we have to understand what that means as far as our involvement in their business. Sometimes they just flat out do not want you in their business. But they may seek other kinds of support from you, and you're going to have to be mindful of what it is they're trying to accomplish, as they're sometimes being a little testy while they're asking you to drive them to the mall. Not an easy thing to navigate, I'm sure. they're also at a point where they're going to be experimenting with ways of being and things to do that we may not necessarily appreciate. And if we can recall our own experiences, they're probably not that foreign to us as well. And we have to be accepting, understanding, but also, I think, have our clear lines in the sand that we're not willing to tolerate people crossing over. But as we're working through adolescence, you're going to be dealing with that. You're going to be dealing with peer pressure. You're going to be dealing with sort of developmentally where kids are supposed to be and what they're supposed to be trying and doing. And so some of that is, again, a careful negotiation for us. And as kids are going through this, we have to keep this piece in mind as well, which is 1 in 5, meaning 4 and 5 are coming along pretty well. They may be testy and grouchy and not tell us anything, but 4 and 5 are not necessarily diagnosable with a mental health problem, but 1 in 5 are. And it's a pretty broad categorization. We're talking about anxiety, we're talking about depression, we're talking about substance use, other kinds of lower base rate disorders. But we have to be able to, when we see a kid struggling in our school or struggling in our home, we need to be able to recognize the difference between a kid who needs some professional assistance versus a kid who just needs a shoulder to cry on or someone to complain to every once in a while. The frequency, intensity, and functional impairment associated with their difficulties may help us make that call. And when it starts to affect their functioning, they can't sleep, they can't go to school, they're not going out with their friends anymore, even though they used to, those may be the reminders that we need to possibly seek assistance. And when we're talking about cognitive behavioral intervention, which is very present-centered, we're talking about the cognitive piece of that is about their thinking. The behavior in the case of anxiety disorder specifically has to do with their avoidance tendencies. And the treatment that we do looks quite different when we're talking with adolescents as opposed to younger kids. With younger kids, it's as much about teaching parents to do the treatment as it is about treating the kids. By the time they're adolescents, though, sometimes the parents are glorified chauffeurs. They bring the kid to the session. The kid doesn't often want the parent to be centrally involved in that treatment. We may find ways to involve them anyway, especially if there's a lot of content that's involved and family difficulty involved, but the kids want to be independent. They want to do it themselves. So we need to be more collaborative in our discussion of what we're going to do. For example, if you're treating anxiety, you're going to have to do some exposure to the things kids are afraid of. And so we're going to have to be collaborative in that discussion, talk more about realistic and unrealistic risks as we would with little guys. I tend not to do that nearly as much as I do with the older teens and with the young adults. Talking about feared consequences, greater use of disconfirmatory evidence in exposure. So I'm not going to get away with giving kids stickers for practicing and trying hard. I'm going to need to talk to them about why I'm doing what I'm doing and help them understand it as well as they can so they can make an informed choice as to whether they're going to join me or not. Because I can't make them do stuff. That's the thing we find most frustrating with adolescents. You can't make them do stuff. It's very difficult. And in treatment, it's probably counterproductive for me to make all sorts of grand claims about what they have to do. They don't have to do anything. And we all have to settle for different ways of communicating with them, engaging them actively in the process and having them own the treatment. You're much better off if you're going to try that approach than simply giving edicts to adolescents. They don't like edicts, and they don't respond well to them for the most part. So briefly going to talk about the literature. First, and this has to do with a term we use in the research side called meta-analysis, which basically means studies of studies. So multiple studies being reviewed at the same time to see, with a larger sample, can you pick out some effects that you may not have gotten in smaller individual studies. So meta-analysis is basically a review, usually a mathematically driven review. And so it helps us get a broader look at what's happening. So when we came to this particular issue, one of the questions is, do adolescents respond any differently to cognitive behavioral or other interventions than younger kids? And when we look at anxiety in general, we don't basically see much. It looks like there aren't major age effects. Adolescents seem to do pretty well. This is 17 studies looking at age-moderated effects for cognitive behavioral response for anxiety disorders other than OCD and other than PTSD. So if you exclude those, looks like there aren't many age effects, which is interesting because in some ways it's more difficult to interact with an adolescent. It can be, as I said, a little bit more of a negotiation in terms of what you're going to ask them to do. They may be less interested in being compliant. And so it's surprising in some ways to see no age effects. And the question then is, why not? And it may well be that if you're having very skilled therapists and very skilled supervisors implement the treatment like you would in these clinical trials that were studied here in this meta-analysis, you may well see that the expert can navigate, negotiate, and work the treatment in such a way that it's flexible enough to accommodate those developmental differences. So that may be why we wash them out. So you may see those age effects in an effectiveness context where the therapists are less developmentally sensitive and less trained. Those are open questions still, but thus far it looked like in anxiety in general there aren't many age effects. So it looks like the adolescents will do just fine. So now the next question is, what do we expect from CBT in general when it comes to OCD specifically? We expect treatment should work pretty well. Looks like you're talking about a symptom reduction anywhere from 40 to 65% in the randomized trials. We're looking at response rates, meaning the percent of kids who are classified as being improved or much improved, 75, 80%. So really quite good. And the studies that have included follow-up up to 1 year, sometimes up to 5 years, the Barrett study was a long follow-up, they attest to the durability of treatment gains. So the treatment is effective and it's durable. The downside, of course, is it's hard to find. So CBT expertise for OCD specifically, you may be able to drive through several states in this country and find absolutely nobody who is an expert in delivering it. So that raises an access issue. But there's also another issue embedded in here, which is we're looking at sample sizes and sample ranges in which we've got pretty broad age range. We've got kids as young as 6, we've got kids as old as 17, which presents, again, a challenge to the delivery of developmentally sensitive treatments. So how do the age effects look specifically in OCD? And the answer is, it's a mixed bag. So there are a couple of different studies. The first two studies are studies that were done here at Penn. The first one was a study of initial treatments, so CBT versus medication. In that case, it was sertraline, versus combined treatment, all compared to pill placebo. And age, in that case, is the ages 7 to 17, was neither a predictor nor a moderator of outcomes. So age didn't affect treatment overall, and didn't affect response to any of those particular conditions. And we got a little bit of a hint of it in another study in which all the kids were already on medicine, and we had more adolescents in that trial. And there was a little bit of a hint towards kids younger than 13 tending to do a little bit better across treatments. And what we saw in another study that I was part of in Norway, the Nordlot study, this is 269 kids with OCD ages 7 to 17 who were treated with cognitive behavioral treatment, the same treatment we did in the POTS studies, in which it became more obvious with such a large sample that the older kids weren't doing quite as well. And the response rate in that study was about 74%. So it was very effective overall, but the adolescents maybe didn't fare quite as well. So we've got some inconsistencies. There are also some studies, large studies done elsewhere, in which age hasn't popped out as a moderator. So sometimes you see it, sometimes you don't. And when you're stuck with that, when you're stuck with inconsistent literature, you've got to make an educated guess. And that's what we try to do. What do we make of it? I think what we make of it is this. When you see an adolescent coming into your office and they have OCD and they're signing up for CBT, or their parents are signing them up for CBT, there's some possibility that their age, that maybe some of these developmental factors can affect outcome, and we have to be thoughtful about how those effects could be realized. I'll talk about that as we go. Bottom line is you've got to be developmentally sensitive. You can't talk to a 6-year-old the same way you would talk to a 17-year-old. Those of us who hang out with kids a lot know that, and certainly those of us who coach, we know that as well. My language is very different when I'm coaching a bunch of 7-year-olds versus 15-year-olds. when it comes to baseball, softball. And we have to be really cautious about matching our discussion to the person in front of us, both to the person and to their developmental stage. So, what do the adolescents bring to the context of treatment? First, they have a strong desire to develop their independence. Some of them are further along in this process than others. We also already know that they have an increased importance of their peer group. So it may well be that discussion of their peer group and the issues that are facing them in general is going to go a long way to helping make those connections. If you know who their friends are and what's going on with this person and what happened with this particular party they were talking about, that may help them feel like you kind of get it and that you're interested in them as a whole person rather than just a patient in your office. And that can help you a lot, because this is very, very much about engaging and enhancing motivation. There's also an ability and desire to think for themselves, which is why I'm so frequently emphasizing this collaboration. This is a collaborative process. I often tell adolescents, I say, look, I'm an expert in this cognitive behavioral intervention for OCD. You're the only living expert on exactly what this looks like in you. So we need to work together, or I'm not going to be able to help you, and I know you're here because you want to get some assistance. So I try to engage them in the process. And sometimes that'll get you an eye roll, but I'm going to continue with that process of trying to engage them and make this treatment about what's best for them rather than what's best for other people. Their risk assessment isn't always accurate. I'm not sure they're quite hooked up to the cortex the way that we are when we're 30. And then OCD could, in some ways, operate as a mitigating factor. Some of my teens with OCD are developmentally, they're behind their peers sometimes because they've been avoiding, because they've been not part of things with OCD interfering and impairing them. So I don't necessarily look at every 16 or 18-year-old the same way either. I want to know what experiences they've had, what kind of friendships they've had, etc. And inherently, there's just comes with the neighborhood, as Mark Twain alluded to. Is there some mistrust of our advice, and especially the advice of people who are trying to make them do things that they don't want to do. So I have to make this treatment feel like I'm not trying to do that. And I've had many an adolescent come into my office and say flat out, "What are you going to make me do today?" And it's not a compliment. And my response to them is usually absolutely nothing. I'm simply here to try to raise some possibilities for you based on how you've been feeling and doing, and you're going to pick. And that if you're not giving them reasons to fight you, that can actually be disarming. So I would keep those kinds of things in mind. Now, this is Anne-Marie Albano's program, which I love the term. It's LEAP, Launching Emerging Adult Program, which basically is trying to encourage kids to make these developmental steps. And what are the key milestones? What do we want them to be at the end of adolescence? We'd love for them to be emotionally and behaviorally independent from their parents. Parents sometimes have a mixed reaction to that, which we'll have to talk about as we go. We want them to develop self-identity. I want them to learn how to manage money properly, develop those skills. I want them to be able to make and keep long-term relationships with people other than their family. And I want them to take control of personal care, which may also include taking control of their mental health care and their mental health treatment. And I'm very overt about that with kids. This is not about your parents. This is about you, and this is about your future. And I'm invested in trying to teach you how to do this so these problems don't get in the way of you doing what you want to do and need to do, rather than having us impose this treatment on them. If you impose the treatment on them, they're going to spit the bit. Simple as that. So, just another comment about how we think about risk, and if adolescence is indeed a risk factor for suboptimal response to CBT, how do we think about that? There's a investigator, a depression expert at Vanderbilt University. His name is Steve Holland. And what he's referred to is every moderator of outcome, meaning a predictor of outcome, reflects a mediator that you haven't discovered yet. So what I'm asking myself is, if I've got some of these things that are associated with outcome happening in a given patient, oftentimes in an adolescent patient, how do I think the negative effects on outcome are going to be realized, and what am I going to do about it? So I need to figure out the why. There are a couple of kind of common whys that we think about with adolescents. First of all, they've had the symptoms longer than their younger counterparts. So are they developing overlearned habits? They've just been at this so long. This is the way I do things. I hear that a lot with teenagers. This is just the way I do it. And when they talk about taking 6 hours to do relatively simple homework because they have to do it perfectly, according to their OCD, this is just how I do things. I expect to be up till 2 in the morning. When you're breaking down that process, you have to pay attention to whether this has just become their way of being. There's also, in some of these kids who've been treated before, we often see this 5, 6 treatments before we even get our hands on them, is pessimism about outcome. What's going to be different? How are you going to do something that my prior therapist didn't do? I've been on medicine for 10 years. I have some reduction, but not enough. What are you going to add to this that's going to make this better? So you have to have that discussion and engage with them, especially if they're overt about that pessimism. But I'll even have this conversation in general. I could imagine that you might be thinking X, and let's talk about that. Psychiatric comorbidity, more common in the adolescents and young adults than it is in the little guys. And comorbidity is really about complexity. So now I've got 2 things, or I've got 3 things, potential targets. And they're often interrelated. So if I've got an adolescent who's also depressed, on top of their OCD, now what am I going to do? What am I going to target first? And if they get depressed because I stress them out during exposure, then how am I going to handle that? So the complexity of the case, in terms of psychiatric symptoms, may be one of the ways that the effects of adolescence are being realized in terms of reduced treatment outcome. Motivational issues and readiness for change, huge issues. There are issues across every treatment, I think. But at this level, I've got to figure out what they have to gain and what they have to lose by doing the treatment. It may be obvious to adults, it may be obvious to people that are around them that they're not functioning as well as they would or they could if the symptoms were lower, but I want to find out what motivates them. And so it'll often lead to long discussions about what matters to them, how do they see the symptoms in their way. Because sometimes if you're talking to a 14-year-old about what's going to happen in college, I had a kid once tell me, I'm 14, what do I know about college? And parents were worried about college, but the 14-year-old wasn't. It's too far away. So what I may need to do is I need to find out how it's affecting things that matter to them now. So what's in the way, and how can I use that to fan the flames of interest and change? We'll talk about that in more detail as we go. And obviously parent-teen conflict about symptoms. We've got a lot of back and forth with families accommodating to try to make the kid's life a little bit more livable, but then the kids are making demands in terms of OCD, reassurance seeking, and other things about who can sit in what seat and who can touch what. Those are really stressful for families because you want to do the right thing by your kid, but at the same time you probably know that you're making things worse by engaging in rituals or doing rituals for kids. And just parent-child conflict in general is going to, the rising tide is going to raise all boats. And so if we've got conflict in general, it may well make the symptoms more difficult and more intractable. So there are times I may need to go and deal with that parent-child conflict separately or sometimes simultaneously, depending on its severity and depending on whether the kid can work around it. So those are kind of things that we start thinking about, and clinically we'll talk about as we go as to how you would deal with those in treatment. So a typical intervention for OCD, what we'd expect to be typical, is about 12 to 20 sessions delivered by either an experienced therapist or someone who's being trained or supervised by an experienced therapist. And what I mean by experience, I mean a subspecialist. That's sort of the optimal view. And at this point, we know that good outcomes are associated with subspecialty practice. We're not as sure about, if you don't have OCD expertise, can you really do this treatment as well? We're just not certain about that yet. So if I can find expertise and I can find someone who's supervised by an expert, at this point I feel more confident. Psychoeducation about the nature of anxiety and OCD. The therapist needs to be able to explain in simple language, in clear terms, how OCD works And there's some pretty basic stuff we'll talk about today, which some of these things may stick, some of them, you're always looking for your own metaphor and language, but we want to explain what OCD is and how it works, and in particular, I want to help them understand that you don't have control over obsessions, but you do have control over your response to obsessions, and that's really where the rubber meets the road in CBT. Anxiety-relevant cognition. What is a person afraid that something bad's going to happen? What is that bad thing? Some folks will tell you, and I think teens may be more likely than the little kids to say that I'm afraid of this specific feared consequence, but not everybody. Some teens just say, I don't like it, it's gross. It makes me uncomfortable, or when I touch something on the left, I have to touch something on the right, more tick-like OCD. And it's not, the world's not going to end, I'm not afraid I'm going to die, I'm just uncomfortable, I don't like the feeling. And so you've got to find out what's underlying these obsessions and what are the consequences of them not ritualizing. You've got to know that to guide treatment. I like to use a hierarchy, so sort of identifying what things are relatively easy but still cause some anxiety versus what things are moderately distressing versus what are the hardest things, the highest level of treatment targets. For OCD, and I think for every anxiety disorder, there has to be, if you've got a willing participant, some form of behavioral exposure to feared thoughts, and in the case of OCD, thoughts and situations. So if I have intrusive images of stabbing my classmate in the eye with a pencil, and I hate the images and I put the pencil down as soon as I get them, exposure is going to involve sitting in your classroom, not putting your pencil down, and it's also going to involve imagining those worst case scenarios so that you can get used to the thoughts, because thoughts and actions are not the same thing. You've got to be a good diagnostician. You've got to make sure that you're not making a mistake. This is an impulsive problem rather than a compulsive problem. But once you've determined that, you've got to do exposure. You have to confront situations. You have to lean into the fear rather than away. And relapse prevention is really important. We don't expect we're going to clear out OCD 100%. I'm going to give you methods that are going to keep it at bay. They're going to get it smaller, get it to not impair your life, but you've got to use these methods. And I wouldn't be surprised one bit if OCD attempts a comeback somewhere down the road. Usually when you're under stress, sometimes it'll start on the same content you used to have, and sometimes it'll come up with something entirely new. So I want to teach these kids well enough to recognize and manage OCD when it reemerges, because I expect that it probably will at least try to do that. I give them that news up front, so no one's expecting perfect outcomes, especially parents. Individual treatment components. I've got cognitive interventions in here that are designed to address those erroneous cognitions. I've got exposure in vivo, meaning prolonged confrontation with anxiety-evoking stimuli. Someone's afraid of getting contaminated and getting sick. I need to come into contact with the things they're afraid might make them sick, and do some low-risk exposure. So touching my desk, touching my trash can, touching the dumpster outside of my office here. We go and do all those things, and we simultaneously will do the bottom one, which is ritual or response prevention. If you touch all these things and you go wash your hands, the exposure is not going to be effective. So I need both things. I need exposure, and I need response prevention. Imaginal exposure, I use that only with kids who've got feared consequences, and I use that, basically I tell them it's like a horror movie. And around teenagers start getting interested in horror movies. And some of them have actually watched the same one many times over. And I ask them, do you have the same reaction to that now that you had the first time? And they say, of course not. I say, well, why not? I say, well, I've seen it a lot. And then that allows me to say, well, we're going to use imaginal exposure in the same way that you've gotten used to The Conjuring, which the first time I saw the trailer for The Conjuring, I was not happy in conjuring that one up. But then over time, you see the same trailer 50 times and you kind of realize what they're doing. You get used to it, and then you recognize that it's a movie. And so I want to get kids to use imaginal exposure in the same way. So to put this simply, I often use this slide with adolescents because they like things to be succinct, and they also like when members of their own tribe come up with the stuff. And so this is a simple way to put why we're doing exposure, how we're doing exposure. And it's really that there's some payoff. It's not just Nike. It's not just do it. There's a payoff for doing it. And the payoff is reduction in the frequency and intensity of discomfort over time. I don't oversell that, but more importantly, it's improvement in their own functioning. When you stop feeding this thing, it's going to get weaker. So, the lessons from exposure, whether it's imaginal or in vivo: anxiety is transient. Avoidance strengthens fear, and exposure weakens it, which is why we want to go right at it. Exposure is necessary for extinction. You can't get used to something you don't do. And also, I think their own experience really brings this home, is anxiety in anticipation of exposure may be higher than anxiety during actual exposure. So I want them to test these things out, especially adolescents and young adults. I want their take on it to be critically important. I don't just tell them this is going to happen. I said, let's go find out. This is my guess. Let's find out. Feared consequences that they may be worrying about may or may not materialize. My guess is they probably won't. I don't give them any guarantees, but I say I like your odds, and I do this stuff myself routinely. And I talk some about letting your anxiety make noise while you go about your business. It's not about making the thoughts go away. That's not what this treatment is. It's about functioning in the presence of that discomfort, that anxiety, those thoughts, going about your business. And as you do that, you may find the thing kind of fades into the background, and eventually you kind of ignore it. That's what we're shooting for here. So the principles of treatment: this has got to be voluntary. I can't make you do it. I'm not going to try to make you do it. I don't want anyone else to try to make you do it. And if they're not ready to do it, there are different forms of intervention we may try. But I'm not going to drag somebody through an exposure hierarchy or treatment that's not going to be effective, because it's going to not be effective if I try to make them. I'll try to motivate them. I'll try to help them figure out that this may be in their best interest, but I'm not dragging anybody, because it's just not going to be worth the time or the effort. It's got to be collaborative. I tend to do it hierarchy-driven, not do the hardest thing on the first day. I try to focus a lot on accomplishment rather than failure. I do this as coach, and I really do this too with my adolescent patients. Because sometimes they're too used to hearing what they're doing wrong. I want to tell them what they're doing right. Every time they come in my office, the first thing I ask them is, what happened this week that was good? And some of these kids are distressed enough, they say nothing. And my response to that is, well, let's go figure it out, because I want to start off by looking at what you're doing that's better, looking at what's going on in your life that's worth fighting for. And so I don't want to just accept that we focus only on psychopathology. That's not where I want to be. We're trying to master anxiety, not get rid of it. And we're trying to manage and face fears rather than running away or giving into them. And I'm really going to tie everything I'm saying to these kids based on the assessment of their behavior I did up front. With parents, I think the biggest role for them is going to be accepting a less active role in treatment, and really a less active role in your kids' lives. I tell people sort of half-jokingly that around 13 or 14, my daughters, who are 19 and 16 now, fired me as an active participant in their lives, and now I'm simply a consultant. And so they may seek my advice. They're not beholden to it, and I'm inclined to treat it that way. And then this way, if I'm not badgering them, they may be more likely to seek me out. So and I think that's probably true of all these kids, but it's especially true with kids who are suffering and struggling, and everybody is stressed out about how they're functioning. I want to help the parents take a less active role. Well, the more involved the parents are directly in the symptoms themselves, the more active that role has to be. So that tends to diminish some. With little guys, we have a lot of reassurance seeking. With teenagers, you see it a little less. But when you see it, you've got to get parents involved and teach them how to do this differently. So as I'm setting up treatment, a few things I want to highlight. This mapping OCD, basically hierarchy, is looking at their lives and looking at their activities and looking at their thoughts and seeing where OCD's influence can be evident. And over time, I'm trying to decrease OCD's influence in as many areas as possible. I want to acknowledge their current position. And sometimes kids will be so hell-bent on telling me how well they're doing because their parents are telling me they're not doing well at all. I want to get away from that. I want to say, look, the truth is probably in the middle, and let's just do the best we can to share our perspectives and not decide what's true or what's not true. And kids certainly are going to be more accurate. The teens are going to be more accurate in telling me what's going on internally, what their obsessions are, and parents may be watching you like a hawk, and they may have a better idea of how long your showers take than you do. And I want to help you take that role on and have you tracking this yourself and not relying on mommy and daddy to give me information. This is your job now. So maintaining focus on treatment goals as I'm moving forward. And if you can't accomplish what we set out to do, always take some due step towards that goal. If I gave you something to do that's too hard, that's well and good. Let's figure out what you could have done or can do now that's a step in the direction we need to go. I'm always moving forward. I just may change the rate with which I'm moving forward based on their response. It's a dynamic process. It's an ongoing discussion, as almost everything is with adolescents and young adults. Ongoing. This concept of flexibility within fidelity. There's things we were trying to accomplish. Certainly I'm trying to get them engaged in the treatment. I'm trying to do exposure. How you do that and how you talk about that needs to be tailored to the kid's interest, to the way they like to think, to the things they like to talk about. So I'm going to give you a couple of examples of how we might do that with an adolescent. It doesn't mean I'm spending time just talking in treatment about stuff that hasn't to do with OCD. I'm trying to tailor my metaphors and my language to the stuff the kids like. This is about engagement. So OCD like Hawaii is one of my examples. And I want to make sure they understand that OCD may have different manifestations and they may have different obsessions and compulsions, but it's all the same thing. And there usually is a big island. So if I've got a kid who's got contamination fear and associated washing rituals, I might label that as Hawaii. But I may have Maui and Molokai as being their concerns about academic perfectionism and their concerns about scrupulosity, for example. And with each of these things, I'm going to create a low, medium, and high hierarchy, if you will. 10 or 15 items that would be a little anxiety-provoking, somewhat anxiety-provoking, more anxiety-provoking. And then I get into the choice. What do you think we should take first? Here are my beliefs about that, but I need to hear from you. Do you want to try to work on the contamination first, or do you think we should go after these thoughts about fearing that you might have done something wrong? And I want their active engagement. I'm flexible about it. I don't want them to choose things I think are not in their best interest, but at the same time, I need them engaged, and I need them discussing it, because I think they're going to take more ownership of the treatment if they're engaged in this process. So I'll use that as a metaphor for explaining how this works, so they don't feel like they have 7 different versions of OCD. You only have one. It just dresses itself in different clothing depending on the situation. OCD is like my dog. Here's another example. And I really get at this in explaining how OCD works. And if I got a kid who likes dogs, if I got a kid who volunteers at an animal shelter, I've got a couple of these kids now, we can talk about animals and use that opportunity to use their interest to explain how things work. Because animals and learning and training animals, it's the same bloody thing. In that OCD is going to be highly responsive to the contingency. So if my dog comes to my dinner table and he begins to beg for food, and I give him food, he may go away temporarily, but I know he's going to be back. And the part of the analogy there is that the compulsions are the feeding of the dog. When you feed this dog, when you wash your hands because OCD said so, it's going to provide you with some temporary relief, and it's going to come back and ask you to do the same thing again. And so that's why we can't feed the dog at the table. We feed him afterwards, or we don't feed him at all. In the case of OCD, I don't want him being fed. I don't want him coming back to beg from me. And so I want to use, again, it depends on the kid. If I get a kid who likes animals, we're going to use up this metaphor. If I get a kid who hates animals, then we're off to something else. If I get a kid who's afraid of animals because of contamination, I'm more inclined to use this metaphor, because there's a bit of an exposure built in. So when I'm talking with a kid who's trying to figure out how they're going to do this treatment, I want to know what they like to do. If I've got a musical kid, I'm going to tell her or him that OCD is like learning how to play the violin, and that you may need to start with relatively easy songs or even just notes and scratch away you will, and you'll get up to the Alison Krauss level as you keep practicing. And that's basically what we're going to encourage you to do, is keep practicing, keep moving, and keep doing your very best to implement the treatment procedures. So if I got a kid who doesn't like music or put down the recorder in second grade like I did, then I may try this one. Kid is a sports kid. And I may say that OCD is like Peyton Manning at the line of scrimmage. And the example there has to do with them understanding what OCD is planning and understanding what OCD is going to do next so you can counter it. So if you know OCD is going to blitz you from the right side, then you change your blocking scheme, you block it up, and you expect if you have success there, it's going to change what it's going to do a couple of plays later. And I really want the kid to understand from their own view, and if they're athletic, this is a really nice way to kind of blend these concepts. And I want you to be attacking the OCD rather than sitting back passively and hoping it doesn't hurt you. I want to be on the aggressive, and with all the sports kids, they completely understand why that's so important. So again, I'm tailoring this to the person in front of me. If they like this stuff, I'm going to use plenty of it. And very much that has to do with engagement. It's got to be interesting. If you think about what they're asking these people to do, come to an office in which you're going to talk to a relative stranger for an hour and a half at a time. That person is going to encourage you to do things that are difficult. And you may not want to do those things. So you better be engaged, and you better be engaging if you're going to get them to get over some of those odd interpersonal humps in order to get this treatment done. And the bottom line is this: OCD is like whatever it is that you like to think and talk about. Match your language to the kid. Match your language to the adolescent's interests. Match your language to where they are. If they're literally just leaving for college, which we've got a bunch of those kids preparing now, we've got to talk about getting to know people at the new university and getting to know how OCD might try to interfere with that process. What's of interest to them, what's of relevance to them, I'm going to make a lot of use of that as I try to explain why we need to be confronting situations that provoke distress rather than avoiding them. So really the heart of the matter is this exposure business. We've got to confront situations that provoke distress while simultaneously refraining from rituals and avoidance. That's what this treatment's going to be really, the fundamental foundation of this treatment is exposure. This is a metaphor I've used. This is the old snakes and ladders game. Some of the people who grew up in this country, this is the British version. This is snakes and ladders, but chutes and ladders. And the idea here, it's a metaphor for using exposure, which is you roll the dice sometimes and you just advance a number on the dice. Every once in a while, you'll get lucky. You'll hit a 4, and next thing you know, you're at 14. Exposure goes better and faster than you would expect. Every once in a while, you're going to roll, unfortunately, and you're going to have a tough exposure. What I tell kids all the time is, as long as you keep rolling the dice, you're going to eventually get to 100. You're going to finish the game. You're going to win this game only by keeping the dice and keeping them rolled. That's what we're trying to get people to do. So we're going to have ups and downs. It's not going to be smooth. It's not going to be linear. It's going to be a process, but it's going to be a process that continues as long as you're engaged and working the treatment the way we need to. As I mentioned before, there's in vivo exposure, which is live. I will certainly do in vivo exposure in my office. I'll also send kids out to practice things between sessions, and those practices are really important. And I need them to be the ones who are in charge. I don't want a 16, 17, 18-year-old or even a 20-year-old having mom be the key or the cue for getting their exposures done. I want this to be done by them. I've certainly resorted to having them set alarms on their iPhones. They all have iPhones. I've texted kids. I've sent other kinds of electronic reminders to kids to do some practices at a certain time. The imaginal exposure basically are as much as we can getting them to work on engaging with the thoughts instead of avoiding them. And you may do that by giving them scripted versions of their worst case scenario and have them listen to them or read them 100 times in a row. Or you may say, when a spontaneous intrusion comes up, I want you to lean into it rather than away. Imaginal exposure, as I said, is imagining yourself the worst case scenario. In vivo exposure is actually doing the thing you're afraid of. You see this fellow touching a toilet seat. He looks a little bit too pleased with himself, so this must be the end of treatment. In the beginning, this is hard. And then as a therapist, your task is to keep people moving through the harder stuff. And the response prevention is basically choosing not to wash, choosing not to ritualize. We encourage people to do this as quickly as they can, to get as complete response prevention as they can, but I don't expect perfection from day one. It's not a realistic goal. But I certainly want to encourage them to do as much as they can. Something odd is happening here. Forgive me.
These things happen.
Indeed. Let me try to close it and reopen it. It was right after my point about nothing being perfect, wasn't it?
Yeah.
How convenient. And the reality is that's how this treatment works. I can get an adolescent come in and say that I did nothing that you asked me to do last week, or my friend had a real problem and I didn't have time to get to your homework. And the question is now, what do you do about that? How do you respond to that? And I think if I'm going to admonish people for being imperfect, I'm probably not going to win any friends, and I'm probably not going to get the kid back on board. I'll probably have a discussion about how I want them to proceed, and we'll troubleshoot together. And if it's a repeated process, if it's 3 times in a row, I'm going to have a conversation about whether they're motivated to do the treatment. So I'm not going to shy away from it, but I'm not going to be a jerk about it either, because they don't tolerate that stuff real well. I'm not sure who does, but and this is another issue. I will put this back up, hopefully. Oh, there she is. This process of disentangling from OCD conversations. And this is an ideal, John March lent me this slide, thank you to John, is the ideal. So the kid asks a compulsive question that the mom knows full well is a compulsion. She doesn't want to reinforce fear, but she wants to answer this in a way that's supportive of the kid and not supportive of the OCD. So I'll actually do this kind of stuff in session, and usually it's me putting the kid in the role of the parent and me in the role of the kid. So I pester them for a while, and I see how patient the kid can be when they're getting 15 questions in a row. And we practice it. So here's what I want you to do. Here's the first pass. Here's the next pass. If your kid persists in asking you the questions, I want you to leave the room, let them know in advance without a lot of, you shouldn't be doing this. I don't think that affect helps me much. And then I want to get them to understand why I'm doing what I'm doing. And if they don't comply with the procedures, we can come in and troubleshoot that too. But I definitely need the parents to be not engaging in compulsions with kids, or otherwise I'm rolling the rock up the hill and having it roll back overnight, like Sisyphus. With early treatment sessions, I try to, as best I can, to the extent that I can, to begin with only the moderately distressing stimuli and intrusions. I coach and encourage them to abstain from compulsions. I reinforce them when they do. And we troubleshoot and plan for future exposure exercises together based on how they're doing. So if you tried this in class and it didn't work so well, what would I recommend you do instead? As they're having success, I'm building upon that. I'm encouraging them to choose from among equivalent stimuli. We could do exposure A or exposure B today. Which do you think would make more sense? I'm engaging them in the process. I'm not just telling them what to do. I want their opinion. I'm interested in their opinion. I'm managing negative family affect when it comes up. Sometimes in the middle of treatment, parents want to start moving faster than the treatment may allow. So I'm going to talk to the parents at that point. I'm going to try to minimize any continuing discussions about disagreements about how treatment's supposed to be done. And anytime I note change in impairment and decreased symptoms to highlight improvement, I want to do that. Even though they're teens and even though they're independent beings, they do like to have it noticed when they're doing things that are smart and in their best interests, and I pepper them with praise, although I'm also mindful of the fact that they're not 7, and I don't give them a sticker and I don't give them a smiley face. I try to do this in their own tone. And I've mastered the tone of sarcasm, which is a language they all speak pretty well. The confronting of the greatest fears, encouragement and praise for effort, modeling where I need to. I'll show them how I do things. I'll show them how I want them to do things, and we'll get as close to that as we can. As I said before, you're discussing risk with these kids because they certainly understand risk. They may even understand other risks better than they understand OCD-related risks. So I want to get them to be closer to the logical people they've become. And OCD is sort of a glitch or an exception. I want them to get them to see that way. Repeated and prolonged exposure with the high items. I don't want them just doing contamination-related stuff in my office. I want them doing it everywhere because that'll promote the kind of extinction that we hope to see and confront that fear across multiple situations and contexts. So with respect to adolescents' risk factors, I think that this issue I talked about before, if they've had this for a long time and they've got pessimism about treatment outcomes, they've been treated 6 times before, I have the discussion. I drag out the empirical literature. I drag out my slide set. I walk them through it. I say, here's what we can expect based on these studies with now thousands of kids in them. And I try to answer the questions as best I can. It's like science lab. I want kids to understand how treatment trials are done so they understand the kind of information that can provide us as we help them make decisions about what's in their best interest. So I'll engage in that process as best I can. Psychiatric comorbidity. That up front, I've got to make a decision. Is OCD my primary target, or am I going after something else? And there are times when I can see OCD is the primary problem, but it may not be the primary target if that secondary problem, such as depression, is likely to negatively impact their motivation, their energy level, and their compliance between sessions. I've sent many kids off to get pre-medicated or have other methods used to treat their depression when I think that their OCD is not going to be treated effectively because of depression. We've seen that in adult trials at the high end of depression interferes with outcome in OCD, and I think it interferes with outcome because it interferes with compliance. So they just don't have the energy to do the work, and I don't want to set people up to fail. I think I need to target that other problem. I'm going to do that and using empirically supported methods as best I can. And I may send people out to do that. If I'm not an expert in depression, I may send them to my colleagues and have the colleagues send them back when they're feeling more up to the challenge of treating OCD. These motivational issues, I've talked a lot about this as we've gone, is I really want them to be fully engaged, and I want to understand from their vantage point, not from their parents, but from their vantage point, what they see the benefit of treatment possibly being, or what they see the risk of treatment possibly being. I want to engage in that process. When I went to graduate school at the University of Rhode Island, we talked about doing these things called decisional balance sheets. So pros and cons of treatment, pros and cons of no treatment, and help the kids see that there's some reason for hope, or we want to address their concerns before we start. And I don't treat people who don't want to be in my office. And that's not what I do. If I've got a kid who's hell-bent on not getting treatment at this time, I may work with their family to try to work on how to reduce their involvement in OCD so they're not accommodating and making things worse, but I'm holding the kids' feet to the fire as well in terms of home rules and treating people nicely at home as best they can. But I'm not going to make a kid do something because it's not going to be successful. They're not going to do the homework, and if they don't do the homework, it's not going to work. So parent-teen conflict about symptoms or other stuff, this is another place sometimes where I've not as commonly as with depression, but I'll sometimes refer people out to work on the family dysfunction, especially if that family dysfunction is going to interfere with my CBT for OCD, and especially if that dysfunction is about bigger things than just accommodating OCD or parents and children disagreeing about how to navigate this. And teens and their adult parents are going to always be ripe for conflict. And so I want to make sure that I'm not referring out when I've got some more kind of basic stuff we can manage in the context of CBT. I refer out when I'm in the position where I feel like this family can't keep it together well enough for me to give this OCD treatment its best shot. And the family intervention that the LEAP program emphasizes, this is for OCD specifically, their goals up at Columbia are to, and I think this is generically true, this is really nicely put, The goals of their family intervention in the context of OCD are to try to reduce levels of conflicts and feelings of anger and blame, which run both ways, by the way. To enhance family problem solving. So instead of yelling at each other, how can we sit down and have a productive conversation? And it may be that you don't have that productive conversation right away. You have it an hour and a half later. I tell parents, with your kids at the sink washing her hands, that is not a fabulous time to discuss what she should have done differently. You have that conversation later. And another goal of family intervention is to facilitate disengagement. So how are we going to get parents out of the middle of these OCD symptoms? And rebuilding an OCD-free family interaction pattern. Because sometimes families are talking about OCD at the dinner table every night, and that's not conducive to living a balanced and healthy life either. And fostering an environment conducive to maintenance of gain, which really I think means giving the reins over to the kid. It is stressful, it is scary, and yet it still needs to be done. It's the kid's life, and they need to take responsibility for it, and they need to have the confidence that we are confident in them. And that's part of what we do in the context of fixing some of these family problems that come up. I actually recommend this book. If you're a baseball fan, you'll know who this person is, Cal Ripken. I love this book because he really talks about how to parent your athletic teams. It has nothing to do with OCD except that the principles of how to support without getting in the way are beautifully explicated in here. And I think this is a value for parents to take a peek at. If they're struggling with how much or how little to be involved and engaged, I think that this is actually a decent resource for how to teach that in a different context. But it's generalizable, I think, to trying to do this treatment. Within school settings, we know there are some of these kids whose symptoms are probably manageable in the context of school. We also know there are some kids whose illness is in the way enough where they need a referral. But even if they need referrals, they're still in school. The school can play a really important role. Regardless, whether they're in treatment or whether they've got subclinical symptoms that school personnel are noticing, repetitive questions, for example, excessive worry about exams and outcomes like that. In either case, the goal is to reduce avoidance and facilitate use of more adaptive coping strategy. And to me, the most adaptive coping strategy is lean into the anxiety rather than away, and let's find out what happens. And oftentimes when you do that, you wind up in a position where the cognition is disconfirmed and exposure provides corrective information. That's what we're really shooting for. And so what are we thinking about from our own, both family and providers? We've got to respect their independence and work within that frame. We want to reinforce their ability and desire to think for themselves. That's part of what we're trying to do. Stay positive even when it's difficult to do so. If they're having a bad day, they'll let you know pretty much right off the bat. And I think you want to ease into these things a little bit with those folks, and not get on them for being grouchy. It's just not helpful. I'd rather try to model that and lead them out of it than confront them about it. It's not useful for the most part. And I make effort to get their world, but I fess up when I don't get their world. So if they walk in wearing a T-shirt of a band I've never heard of, I'll ask. If they walk in wearing a T-shirt of a band I have heard of, and the advantage of having 16 to 19-year-olds is I've heard of a lot of bands, I'll make some note of that to try to enhance our connection and let them know I'm paying some attention to what's going on in their worlds as well. I try to ignore tone, but when somebody crosses a line, I call them on it. And a lot of families sort of get up the ship here because the kids are so on edge and grouchy and irritable that they sometimes let kids get away with stuff at home that other parents wouldn't, because they're worried about the kid's experience, and they're worried about, I can't parent this kid or I can't discipline this kid because she's already suffering so much. And my reaction to that is that's not setting the kind of context that we want to for her living in the context of these symptoms and managing them and not taking this out on other people. So I want parents to try to understand where that line is for them. And the bottom line for me as a therapist is I don't want to be one of those adults that they mistrust. When they ask me if I'm going to make them do anything, I really tell them I'm only here to make you aware of the consequences of the choices you make. I'm not here to make the choices for you. These are your choices. Here's what I think is going to happen if you do the exposure. Here's what I think is going to happen if you don't. And in the end, I want you to pick. And I have a clear rooting interest. I think you should pick the ones that are likely to yield reduction in functional impairment, but this is your treatment. It's up to you. It's your hour. You tell me. And I think when you have that reaction to them, you give them fewer walls to push against, and they tend not to push as much. And maybe you can make them more productive in your session, and that may help them be more productive between sessions as well. I believe that's my last slide. So thank you all for listening, and I really appreciate it.
Well, Dr. Franklin, thank you once again. That was a great presentation, and kudos to you for handling that little technical glitch there. There wasn't even hardly a couple of seconds of dead air, so you did that really well.
I do what I can. Filling dead air is one of my skills.
Well done. Thank you. All right, so we do have some questions, and I'm going to kind of launch right into those, okay?
Sure. Yeah.
Let's see. What do you do about a teen who is 13 and a half with TS, ADHD, and anxiety, and ODD? So you've got a teen with a lot going on who doesn't want to go into individual therapy. Is group therapy appropriate, or just it's not clear whether it's no therapy at all or whether, you know, what do you think?
Well, of all those things, I would think that probably the most important one to get a handle on is going to be the ADHD. Because if you look at adult outcomes, I know Larry Scahill, who's an expert in Tourette's, has looked at the data out of Yale Child Study Center and basically found on some of their reviews that untreated ADHD in terms of predicting adult outcome was a lot more important in predicting negative outcomes than untreated Tourette's. Because sometimes people will make that decision about, I want to only treat the tics, I don't want to use ADHD medicines when the kid has tics. And Larry's data would imply that maybe isn't the best way to go. Untreated ADHD can be a major impact on education, on achievement, on how kids feel about themselves in terms of their ability to learn. So if I have a choice of any of those things, and it may be the ADHD, maybe because of the power of medication in that case, it may be something you look to reduce ADHD symptoms and see what it leaves you with. So my sense of it is you've got refusal. You know, kids can sometimes say, I'm not going to do anything, and then I think that the contingencies at that point are going to be, here's what's going to happen if we are in this situation where you're not choosing something that's in your best interest, and we may well try to engage them in that process. There certainly are efforts being made by therapists to do motivational readiness, motivational interviewing. So if you have some of that expertise in the treatment provider, simply to help the kid formulate some of their own ideas about what they want or don't want. Those are ways I think I would consider. But to me, if I'm looking at that sort of constellation of symptoms, I want to see what I can get done with the ADHD first. In most cases, the ADHD is mild, but the OCD is bigger. Then I may make a different decision. But for the most part, CBT is a form of teaching. Now, if I've got untreated ADHD, especially in a kid that's older, my concern is how well am I going to be able to teach this kid if those symptoms are interfering with their ability to learn. So I may shoot for the ADHD first in that case.
Okay, thank you. What happens when you are stuck at a certain stage of an exposure? And the example given is that the individual stood in the elevator for 10 seconds and won't do it anymore.
Yeah. That's a great question. And it happens with some frequency. It depends in part on what the exposure was supposed to be. It depends in part on where they are motivationally. If they're having a panic attack, I might resort to some diaphragmatic breathing, but if it's not so much a physical reaction as it is a psychological or emotional one, I'm going to do what I can to be supportive. So the first thing I'd say is this. If someone is very anxious and very angry because they're anxious, and they're escalating, I'm going to make sure I'm de-escalating. So my voice is going to get quieter, I'm going to get slower, I'm going to get calmer so that I'm not exacerbating that reaction. And I'm also going to be showing them that I'm not afraid of their reaction. And I'll also at that point, I'll often wheel out the hip pocket patient. So examples of other people, other kids, other teens who've been in these circumstances where the exposure turned out to be harder than they guessed. I'll often apologize to a kid flat out and say, this one's on me. I thought we were ready for this one. Maybe we're not. But I'm not going to give up the ship. I'm not going to say, therefore, exposure is bad. I'm going to say, well, let's think now about what, if anything, we could do to cut this exposure just a little bit so that we can take that step back in order to move forward again. I still want them to complete the exposure, and exposures don't hurt people. But leaving an exposure in the middle can hurt your treatment. So I'm inclined to try to figure out what can I do. How can I backpedal? How can I sell the idea of staying here even though you're really uncomfortable? And then if they do that, I want to reinforce the heck out of that because their reaction during that sort of misstep is going to be critically important to setting up the rest of your treatment. So I'm not going to give up, but I'm not going to also just press them and admonish them for having a strong reaction.
In that case of the elevator, would it be like you stand in the elevator with the door open and it never closes? Yeah. Is that
that's exactly what I'm looking for. Are ways to make that easier. So if they say going to the 16th floor is harder than going to the second, then we'll go to the second. And it might take me 16 elevator flights to get from the first floor to the 16th. But if a kid's in an elevator and then they run out of the elevator, I'm going to need to find a way to get them back in that elevator.
So how often would you do that then? As many times as it takes, or? Yep,
exactly. And I wouldn't put a hard number on it, and I wouldn't tell them it's going to be done in this amount of time. I say, well, okay, this proved a little challenging. This was a tough one.
Okay.
And let's think about how we get back in here.
All right. We have a number of questions from some educators, and I think this is an area that they have interest in. So I have one question that it sounds to me from the description here that the student has school refusal.
Yeah.
And they are getting outside therapy. And there's been modification and so forth to schedules and stuff like that.
Right.
And as much as the student at least getting into the building and then going to see the case manager and so forth. But how do you move beyond that? Like, what's the next step? Just keep adjusting it to they go to a different classroom maybe, or they go to the library, or what? How do you move that forward?
I look for I have them guesstimate with me as to what situations within school are going to be a little anxiety-provoking, somewhat, and more. We can't control what happens in the school, though, right? So people come by that you don't like, and that's going to raise the level of anxiety whether you planned it or not. So what I'll do is I'll get a decent map of the school. Have them draw me a map of the school, and we'll literally walk through it and say, okay, if you were here with one person, how would this be? If you were here with 8 people, how would that be? Give myself some way to estimate what I can get accomplished. And I always tell people something is better than nothing. And the people I tell that to most are schools. Because I've run into some situations in treating school refusal where they either have to be in school completely or they're out completely. And what that basically does is it takes away the rungs in my hierarchy.
Mm-hmm.
So I need to get as much cooperation as I can for schools. And sometimes I'll get a kid back into a class without necessarily having to be, at least for a short while, responsible for the work. But there's no way around that. Ultimately, they're going to have to get back to school if they're of a certain age, and they're going to have to do the work. So I may get them back in the building and then get them back in the classroom and then get them back into the work. That may be a process that takes 2-3 weeks. We don't want to be in a hurry because we're talking about 4-6 years. So I really want to make sure that I'm working actively with the school. I've got a number of cases like this right now. We're now putting back in responsibility for completing homework assignment. Now the kid's back in, now he needs to do the stuff that needs to be done in school, for example, and that includes completing homework. And we may do that, with one class at first, and work our way up to the whole 5 or 6 classes that he or she is taking. But a hierarchy-driven approach is probably going to be your best bet.
Okay. Another school question. A student, I'm not sure how old this student is, but this student with OCD obsesses over grades and outcomes and so forth.
Yep.
And the behavior may come out comes out at home as well as with obsessive studying. So how can the school help in that situation?
Well, I mean, I suppose it depends on the age of the kid. It depends on where they are academically on the calendar. I mean, there's no question. It's difficult to convince people the SATs are not important. At the same time, it's probably, you may get some traction in thinking that a paragraph essay about Dr. Jekyll and Mr. Hyde is not going to make or break their academic future. And so you find some of those lower level things and you work your way towards it. I referred to this at a recent talk of mine as being something we all suffer from, it seemingly now, is a bee phobia. And I don't mean the insects. I mean parents and kids who are in schools who are terrified of the prospect of getting less than an A. And so I want to make sure that I'm not collaborating in any way if I'm a school and saying that, yes, indeed, if you get a 93, I don't think you're going to get into any decent schools. That's just flat out not true. And it's a message that may be used to motivate the unmotivated and may actually make the highly motivated worse. So I want to be careful who I'm using these messages to motivate and what messages I'm giving.
Mm-hmm.
And
this is
so
a 16-year-old, by the way. Just I got another message.
Yeah, which means SATs are looming, and there's no question in my mind that they always tell you that junior year is the most important, and that gets the kids who don't care about that. They don't even listen to you, and the kids who are already worried that junior year is the most important are now up till 2 in the morning. So I'm hitting the wrong people with the wrong message. But I want people to do well. I also talk about balance. I talk about making sure that kids are not just their grades. One of the things I tell them is I work here at Penn, and Penn is sort of a scary place when you apply, and because everybody has high SATs and everybody has high grades, and so if someone hands me a stack of 100 applications and I've got to get rid of 90 of them, the high grades and the high SATs are not going to be enough to differentiate. So I'm looking for other things. I'm looking for somebody who's interesting. I'm looking for somebody who's had an experience that maybe shaped their thinking in a way that's going to contribute to my campus environment in a positive way. Mm-hmm. So I want to make sure that they understand that they may be so focused on these grades as meaning something, but I'm not sure the schools are quite as much sold on that. And if you talk to admissions directors, they're looking for kids who are interesting more than they are looking for kids with perfect scores. And another myth that we've really perpetuated in this country is that there's only about 7 or 8 colleges worth going to, and everyone else is going to be living in the streets. It's just flat out not true. It's fantastic marketing by the subset of schools that benefit from it. But most people don't go to these elite places, and they wind up with perfectly fine, interesting lives. We don't want to reinforce these messages. I don't want to pour gas on the fire with these kids. I'll often ask kids, where do you suppose I went to undergraduate? And then when I mention where I went to undergraduate, they look at me and say, I've never heard of that place. And I say, that's precisely my point.
All right. We've run well over, but I do have one more question that it touches on kind of another favorite topic of yours, which we didn't talk about here specifically, but we did certainly cover OCD. So I have a 19-year-old who refuses to clean his room to the extent that he is hoarding food and dirty dishes, etc. So a little bit of OCD with regard to the hoarding and so forth.
Yeah. And I suppose I'm interested in, at that point, what's the rationale? Because sometimes people don't clean the room because they don't have the energy. Sometimes people don't clean the room because they think everything in it is important. Sometimes people don't clean the room because everything is sentimental. So what I need to understand better in order to help provide some specific advice, what the logic is, what the history is. OCD, hoarding, we do see it on occasion starting in teens. But I also think there are house rules and there are responsibilities we all have for living in a home. And if this is happening in the midst of my home, we need to get this addressed. I can't have you hoarding food when I've got the possibility of rodents. And so we need to have a serious discussion about how you're going to address this. I'm happy to help you. I'm happy to help you find somebody who is an expert in this problem if I can. And there are lots of different approaches to this, but the bottom line is you're under my roof, and I can't in good conscience permit you to do things that aren't healthy and aren't safe, and we're going to have to discuss how you'll address it. Simply not addressing it is not okay. That's not good enough.
Well, I got another message from, I would assume, this mom, and she said that he says neatness doesn't matter. So that's his apparent rationale for,
right.
And
neatness doesn't matter. That may be his value, but he's also living in your house, and there's some minimal amount of neatness that does matter to you. And I would think that you would be in a position to have a discussion about what that means. He's not 7, so you can't just go clean his room necessarily, nor would I recommend it. But I think if he's not saying this is a symptom, if he's saying this is a preference, then all the more reason to say that that's your preferences are your preferences. That's not okay in my house. So let's think about how we're going to fix it.
All right. Well, I think we're going to end it here. Dr. Franklin, thank you so much. A lot of great information. There are quite a number of questions that are left, and they will end up on the blog. So I hope folks will tune in for those, or dial into log on to our website is the expression I want to use, and look for the answers there. I'm going to sign off and turn this over to Kelly for a wrap up.
Hey, thank you all for joining our webinar, OCD, Teens and Young Adults, How to Keep Them Engaged in Their Own Treatment, Symptoms, and Lives. I hope you enjoyed it as much as I did. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that weren't covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, Tourette Syndrome and Autism, Similarities and Differences, will be presented by Dr. Mark Mintz and is scheduled for next Wednesday, May 13th, 2015. This ends tonight's webinar. Thank you, Dr. Franklin, for your presentation, and thank you, everyone, for attending. Good